and case studies. So we are going to travel through the OPG in the following manner, that is starting with introductions, synonyms, historical development, basic concept of tomography, practical application of working principle, normal anatomy, real and ghost images, advantages of OPG, disadvantages, common errors made in panoramic radiographs, interpretation, and conclusion. Finally, we are ending up with references. All the contents quoted in this webinar are obtained from the review of literature and from the renowned textbooks of oral medicine and radiology. What is the term panorama? Here in the picture, we can clearly visualize that it is an unobstructed wide-angle view of a region. Panoramic radiography can be called as or in different terms like panoramic imaging, pantomography, automopantomography, rotational panoramic radiography, dental panoramic tomography. Commonly, in simple terms, we call it as a OPG. It means autopantomograph. Moving on to the historical background, the first attempt to image the entire jaw was attempted in the year 1922. The OPG machines and the techniques has undergone many revolutions and evolutions. The latest technique was introduced by the Patro and Numata. Different companies are sponsoring or manufacturing different OPG machines in their brand names. Recently, we have a digital and fully automated OPG machines. Here, you can clearly visualize the OPG machines. Let's start with how we enter the OPG room. Once we receive the patient, we greet the patient, we ask them to remove all the metal belongings in which the patients are wearing, like the earrings or hairbands, hair clips, or any dentures present in the oral cavity. We'll see the importance why these structures or metal objects have to be removed, because these metal objects will produce geometric distortion in the OPG machine. Here in this machine, let's have a general introduction that here we have a stand, the X-ray source and the sensor. Other thing is a bite block is present. In the bite block, different slots are there. Depending upon the patient age and the height, we can adjust the slot of the bite block. And here the patient has a hand rest. Here digital display is present. In this digital display, we can adjust the kVp, milliampere, whether we want to take the OPG or TMJ tomography. And here laser sensors will be present in the stand. This laser sensors will be used to draw the midline of the patient and ortho the y-axis and the x-axis. Here we have a stat to position the head of the patient to prevent the patient from slanting or bending forward and backward. This is an important step in the preparation of patient for the OPG. So while comparing with IOPA and OPG, let's see where the exposure is highest. That is, in OPG machine, here we have a fully automated, that is with a kVp setting of 72 and milliampere of 8. The exposure time required is 18 seconds and dose received by the patient is 0.103 milliroentgens. When we have the kilo voltage peak of 80, the dose received by the patient is 0.116 milliroentgens and the exposure time required is 15 seconds. Whereas in the case of IOPA, when we take a full mouth radiographs with the help of IOPA, that is nearly 14 intraoral frames, dose received by the patient is 0.712 milliroentgens. So the X-ray radiation received by the OPG is literally less lower and minimal when compared to the IOPA. This is a major disadvantages of advantages of OPG. We are moving on to the working principle, how this OPG works. That is depending upon the two principles. We call it as a scanography, or the other one is a tomography. Scanography means slit beam and the tomography means slice or a section. Normally, while taking OPG, we can see that the patient is standing straight and erect. That is, the patient is stationary and the X-ray source and the X-ray film or the sensor rotates around the head of the patient. So when the X-ray source is rotating around the head of the patient, different slits or beams of X-rays are traveling throughout the patient's facial regions. Here, for a clear interruption or clear picture image of the OPG, there should be a same velocity and speed between the sensor or the film and the X-ray source, so that only we can sharply record the film on the image. What are the types of panoramic images we can obtain in an OPG? There are three different forms of images. We call it as a single real image and double real image and ghost image. Let's see different forms of images in detail. Starting with the ghost image. Normally, now we can see that the image, one is a real, another is a ghost. Name itself indicates that is a duplicated image. Under real image, we have a single image and double image. What is ghost image? Ghost image are formed by the dense objects located between the tube head and the rotation center. These ghost image usually results from external objects such as earrings, or they may be produced by dense anatomical structures such as the mandible. So only we are asking the patient once they enter the OPG room to remove all the metal belongings which the patients are wearing. Even we ask the patient to remove the neck chains what they are wearing. Let's see what is this real image. Only one image results from a given anatomical structure, that is, the X-ray passes through the image only once. Most images seen on panoramic films of this type, examples the mandible or the condyle. Double real image is two images of a single object or seen on the film, and double real images are produced by the structures located in the midline. The X-ray beam passes through these objects twice as the tube gauge rotates around the patients. That is, the structures results in the double real images or the hard and the soft palate, hyoid bone, and the cervical spine. In the following OPG, we'll see how the double images are obtained. See, this is a X-ray beam are passing through the structures, facial structure, the slit-like structures or radiation or entering through the facial bones only once. In this checkboard appearance, here we can see the X-ray beams are appearing or entering the patient twice. So we are getting real images, double images, and next slide we see what is a ghost image. Ghost image is how can we identify a ghost image? Why it is of so much importance in the OPG? It is the unsharpness which is in horizontal direction. Here you can clearly visualize this is a mandible reconstruction plate, and here we can see the ghost images, that is unsharpness which is in horizontal direction, always projected at a higher position in the radiograph than its real counterpart because the beam is directed from below and the image is always reversed. Here you can see the ghost images of the reconstruction plate of the mandible. It should not be mistaken for any pathology or any bony lesions or any geometrical distortions. Next, we are moving on to the normal anatomy. Normal anatomy, we are going to see about the different structures present in the OPG, and we call it as a real or actual shadows. In this, we are going to see about the teeth, mandible, maxilla, hot palate, zygomatic arches and zygoma, styloid process, hyoid bone, nasal septum and concha, orbital ring, and base of skull. This is a schematic representation of a OPG, and different structures are labeled, and in the real OPG we'll label the structures individually and we'll be repeating the structures frequently for a clear understanding. The other structures seen in the OPG are the tongue, soft palate and uvula, lip line, ear lobes, nose, and labial folds. The ashodes commonly seen are palatoglossal airspace, nasopharyngeal, and glossopharyngeal. Next things are the ghost or artifactual shadows. Here we have a cervical vertebra, body, angle, ramus of the contralateral side of the mandible, and the palate. Here also we have a systematic representation of the air spaces. This air spaces represents the shadows. These air spaces represents the shadows present in the OPG. Clearly understand these slide or note the slide that we are going to label the different structures in the OPG in the following manner. Here, this is a normal skull, and below we have a radiographic image. Starting from So we'll see what is number 9 is starting. Number 9 represents the external auditory meatus. Moving on to number 12, we have number 12 represents the lateral wall of the orbit. And the number 5 represents the zygomatic arch. Number 25 represents the sigmoid notch. And number 14 represents the infraorbital foramen. Next, we moving on to number 19. Number 19 represents the inferior meatus, and the number 17 represents the nasal septum. Kindly follow me according to the number, so we'll have a clear idea about the anatomical structures. And the number 18 represents the nasal spine. Number 13 represents the infraorbital canal, and the number 7 represents the zygomatic temporal suture. Number 6 represents articular eminence. Number 22 represents maxillary tuberosity. Number 39 represents the hyoid bone. See how the clearly structures are visualized in the OPG. In spite of this structure, here we can also see the air shadows and also distortion and also overlapping of the images are seen in the OPG. So before interrupting the OPG, we have to clearly understand the normal anatomical structures. So in the other slides, we'll be frequently repeating the normal anatomical structure for your clear understanding. Here, this is an edentulous patient. Here, you can follow the arrow marks clearly to understand the structures. That is starting from the posterior wall of the pharynx, soft palate, dorsal surface of the tongue, middle meatus.
It is not available.
Inferior nasal meatus, inferior nasal concha. Ghost images the opposite side of the mandible, upper lip and lower lip. Here now we are going to see the air spaces. That is, what are the air spaces present over here? That is, number 46 represents the palatoglossal air spaces. Next, number 43 represents the pharyngeal air spaces. Number 40 represents the tongue. Number 42 represents the uvula, and the number 41 represents the soft palate. Number 21 represents the hot palate, and number 47 represents the glossopharynx, and number 45 represents the glossopharyngeal air spaces. So in the OPG also, we can clearly visualize the structures corresponding to it. The air spaces are so important, that is because we can see the overlapping of the air shadows in the OPG. Normally, while taking OPG, we'll ask the patient to bite the bite block. That is, a bite block will be present. They have to keep the bite block in between the central incisor, and we'll ask the patient to touch the tip of the tongue in the hot palate to prevent or minimize the amount of air spaces. If the patient opens the lip, or if they are not touching the tip of the tongue in the hot palate, we'll experience geometric distortions in the OPG. Let's see what are the structures present over here. Kindly follow with me the different numbers of the OPG structures. That is, number 26 represents the sigmoid depression. Number 24 represents the coronoid process. Number 11 represents the middle cranial fossa. Number 8 represents the zygomatic arch. Number 15 represents the infraorbital canal. Number 16 represents the inferior concha. And the number 2 represents the pteriomaxillary fissure. Number 1 represents the maxillary sinus. Number 3 represents the pterygoid plates. Number 4 represents the pterygoid hamulus. Number 32 represents the lingula. Number 31 represents the mandibular foramen. Number 23 represents the condyle. And the number 44 represents the ear lobe. Number 30 represents the mandibular canal. Number 36, that is a mental fossa. Number 38, mental elevations or tubercle. Next, number 34 represents the mandibular gland fossa. Here, you can see on the right side, the air spaces which is clearly visible. That is the posterior wall of the pharynx. Here you can see that the shadow which is clearly visible on the right side close to the ramus of the mandible, that is the posterior wall of the pharynx. Here we can clearly visualize in this OPG. Now we see the repeated anatomical structures, and the first we see the ghost images of the hot palate. We have seen that how the ghost images is obtained. Ghost images are usually obtained or present in a higher position. Moreover, it is not of the same radio opacity or as that of the original image. So we have to understand what are the structures present in the OPG, and it is important to understand the ghost images also. We should not take it for a normal anatomical structures. Here you can again we repeat the few structures present in the OPG for your clear understanding. That is for number 23, pterygomaxillary fissure. Number 23 is a coronoid process. Number 2 is a pterygomaxillary fissure. Number 17 is the nasal septum. And number 16 is the nasal fossa. Number 19 is the inferior meatus. Number 8 represents the pterygoid plates. And the number 21 represents the hot palate. Number 6 represents the number 6 represents the articular eminence. Here also we have labeled the different structures for your clear understandings. That is number 9, we repeatedly see like a foramen-like structure. So that is the external auditory meatus. Number 13 is number 3 is the pterygoid plates. Number 20 represents the incisive foramen, and number 11 represents the zygomatic arch. This OPG can also be used to visualize the age of the patient depending upon the eruption of the tooth. Can you guess what will be the age of this patient? The age of the patient is 10 to 12 years. The structures, again, we are repeating, it is the atlas, transverse foramen, pterygomaxillary fissure number 2. Number 31 is the mandibular canal. See, we have labeled the different structures. And what is the positional error seen in this film? That is, the anterior teeth are positioned behind the notch in the bite block further from the film, resulting in the widening of the anterior teeth. So all these things you have to know. All these things you have to know to prevent that it is an anatomical variation or enlarged incisors are present. So depending upon usually we place a bite block while taking the OPG. If the patient mistakenly bites it has a groove in the bite block. We will place it the patient or ask the patient to bite it in the groove. If some patient has not bited it properly, whether they're placing the incisors in front of the groove or behind the groove, it results in the enlargement of the incisors or foreshortening of the image occurs. Let's see what the head position error is seen in this film. Here we can see that the head is tipped down too much, resulting in shortening of the mandibular incisors, and the mandible appears V-shaped. The different structures seen in this are lymph node, that is the calcified lymph nodes also can be visualized in the OPG. Next is an epiglottis. Most of the time we forgot to notice the epiglottis which is appearing in the OPG. See what is the white radio-opaque area indicated by the red arrow. That is the lead apron was placed too high on the back of the patient neck. Here you can see the air cells in the zygomatic arch. It should not be mistaken for any cystic lesion or any pathologies. Here this is a pattern on the right side of the film is caused by excessive hair on the patient hair. See here we can clearly visualize the coarseness of the structure. In the OPG, we can see that the red arrow indicates the fracture line present. Here we can see the separation line between the fragments. The green arrow, here we clearly identify that the green arrow identifies the pseudo fracture caused by the palatoblossal air spaces, and the red arrow indicates the odontogenic keratosis. So next we are moving on to the slide. Now we can clearly visualize that why we are asking the patient to remove the metallic objects once they entering the OPG room. Here we can clearly visualize the earrings or shadow of the earrings, and their ghost images are seen in the OPG, which produces a geometric distortion of the image, and we are not able to interpret the image properly. So only we are asking the patient to remove all the metal belongings. In this images also ghost images of the earring are seen. Hearing aid also we should ask the patient to remove it as it produces ghost images on the contralateral side. Here we can see that the ghost images of the reconstruction plate of the mandible. Ghost images of the mandible, that is the dotted line outlines the ghost of the left ramus angle over the right side of the mandible. What happens when we are not positioning the patient properly? It is an important restrictions, or we should give to the patient to remain or to keep the head straight, and the patient should remain or stay erect. When the lips are not closed, what will happen is the lip shadow will be seen on the OPG. When the chin is tipped too high, the maxillary teeth roots are superimposed and the maxillary incisors appear blurred. Flattening of the occlusal plane or reverse smile line occurs. So all this we should know before interrupting the OPG. What happens when chin is placed downward? That is, the mandibular incisors appears blurred. The apex of the lower incisors are out of focus and blurred. One or both the condyles may cut off from the radiograph, or increased curvature of the occlusal planes occurs. See in that photograph also we can see that the patient is looking downwards. So we should clearly instruct the patient to follow the instructions while we taking the OPG. When the patient is positioned too far forward anterior to the focal trough, the anterior teeth appear blurred, narrower and out of focus. Spine is superimposed on the ramus area. When the patient is positioned too forward posterior to the focal trough, the anterior teeth appear blurred, broader and out of focus, and ghost images of the mandibular spine is more prominent. When the patient head is tilted, we should not interrupt as any facial asymmetry. It can be occurs due to the tilting of the patient head towards the one side. That is, one side condyle appears larger than the other side. It doesn't mean that it is a condylar hyperplasia. We have to rule out the positioning errors in the OPG. The side tilted towards the X-ray tube is enlarged. We should ask the patient to stand straight to prevent the overlapping of the spine. That is, it appears as a radio-opaque artifact in the center of the film, superimposed on the anterior region. So, how we interrupt the OPG? Before going into the interruption, we'll see what are the advantages and disadvantages of this OPG. Namely, for the advantages, here we have a broad coverage, low radiation dose. Technique is very easy. For trismus patient also, where we can very well visualize the oral cavity, and other thing is the quick and the patient education, and for case presentation we can use the OPG. The major disadvantages associated with OPG are low resolution, image magnification, superimposition on the image occurs, requires accurate patient positioning. So we have divided the entire OPG into 6 zones. See what each zone represents. Let's see the OPG. That is, zone 1 represents the teeth and the surrounding structures. Zone 2 represents the nose and the sinuses. Zone 3 represents the inferior cortex of the mandibular body. What the zone 4 represents? Zone 4 represents, that is, condyles are centered in this zone. Zone 5 represents the ramus and the spine, and zone 6 represents the hyoid bone. For easy interpretation, we have divided the entire OPG into 6 zones. So that is, the orthopantogramming should be viewed as if you are looking at the patient, that is, with the image of the patient left side on the operator right side, and should be viewed on a view box with sufficient light. A thorough knowledge of the normal anatomical landmarks and the superimposed structure is mandatory. The potential artifacts associated with the patient and the machine movement and the patient positioning and usual patient anatomy had to be identified and understood. For this reason only, we are continuously repeating about the ghost images and the superimposition of the ghost images, and for thorough understanding, we should have a thorough knowledge about the normal anatomy which is present in the OPG and the air spaces. So radiological interpretation of facial trauma, you see what we look for, whether we are look for a mandibular fracture or maxillary fracture, it seems to be a fracture is present like that. So what are the signs we can see while interpreting the fractures? That is, first we should access the periphery and corners of the image, examine the outer cortices of the mandible, examine the cortices of the maxilla, examine the zygomatic bones and arches, assess the internal density of the maxillary sinuses, assess the structures of the nasal cavity and palates, examine bone pattern of the maxilla and mandible, and the alveolar process of the teeth. It should be in a systematic pattern while interpreting the OPG. Normal radiographic signs we can see for the fractures are there will be a separation sign between the fractures, or sutural diastasis can be there, overlapping signs can be seen, abnormal linear density or a line-like fractures can be seen in the OPG, disappearing fragment sign mostly occurs with the condyle, and next is an abnormal angulation or stiff deformities. These are the radiographic signs of fracture where we can note it in the OPG. So in mandible, following from the condylar process and the temporal mandibular joint, we have to carefully examine it for any condylar fractures or missing fragments at segment fractures we commonly notice in the condylar process. Next, we have to go through the coronoid process, ramus, body and angle, followed by the mandibular dentition and supporting alveolus. Next, for the midfacial region, the cortical boundary of the maxilla, including the posterior tooth, pterygomaxillary fissure and maxillary sinuses, zygomatic complex, inferior and lateral borders of the orbit, zygomatic process and anterior portion of the arch, nasal cavity, concha, maxillary dentition and supporting alveolus. Here, let's clearly visualize the cortical boundary of the maxilla, including the posterior border, pterygomaxillary fissure. Clearly visualize the arrow marks representing the pterygomaxillary fissure, the zygomatic complex, inferior and lateral borders of the orbit, zygomatic process and anterior portion of the arch, nasal cavity, concha, maxillary dentition and supporting alveolus. Moving on to the case or case. Can you identify this radiolucent lesion present? That is, a 40-year-old female was referred by an oral surgeon to obtain a panoramic radiograph. Her chief complaint is mild discomfort in the lower left region. A cropped panorama is displayed, a moderately well-defined radiolucent associated with an impacted tooth. What abnormality is depicted in this panoramic image? Here it is associated with the impacted tooth. We can say it is as a dentigerous cyst. Dentigerous cyst clearly visualized is originates the cemento-enamel junction encircling the crown of the tooth. Usually cysts are unicystic, and usually normally cyst or any lesion have two types of border, whether they have a corticated border or sclerotic border. Corticated border are thin and very well defined, where sclerotic borders are not well defined and they are little bit thicker in size. Sclerotic borders, where it occurs is at chronic infection, we can note the sclerotic border. Next case presentation, clearly see the OPG, that is a 90-year-old female present to the Department of Oral Medicine and Diagnostic Clinic. Radiographs were obtained and the panoramic radiograph showed a well-defined round radio-opaque supernumerary distal to the third molar. The likely diagnosis is distordens. Distordens, the structure seen over there is a tooth-like structure, which is a supernumerary teeth. We call it as a distordens. Here, what is that? A 60-year-old male represented to the Oral Medicine and Diagnostic Clinic, and radiographs were obtained, and the panoramic showed generalized enlarged root that were well defined and radio opaque, and this is an intact periodontal ligament space surrounding the roots of the teeth. What is the likely diagnosis is the hypercementosis. Hypercementosis occurs due to the excessive deposition of the cementum. Here, intact lamina dura and periodontal ligament space. Usually, the patient is asymptomatic. Here, what is the likely diagnosis? That is, a 40-year-old African-American woman was referred to evaluate the radio-opaque entities surrounded by the radiolucent structures centered over the apex of the tooth. Upon vitality testing, both the teeth were vital and no history of pain or sensitivity is noted. This diagnosis is a periapical osseous dysplasia. It should not be. We have a differential diagnosis, periapical granuloma, any other lesion. The most common is a periapical osseous dysplasia. What is this? What is that? A 60-year-old woman presented to the oral medicine and diagnostic clinic. The panorama revealed a cluster of small, ill-defined radio opacity found at the mid portion of the right mandibular ramus. Have you ever come across these structure? It is nothing but the tonsilloliths, that is calcification of the tonsils or deposition of a calcium crystals presence in the tonsils. What happens? This tonsillolith appears in the ramus. See, the image is superimposed over the ramus of the mandible. This tonsillolith will produce pain and difficulty in swallowing in the patient. Sometimes it has to be removed surgically due to the pain while swallowing, and also it produces halitosis. It occurs due to chronic superinfections of the tonsils. Here, what is this structure? Radio-opaque structure present in the maxillary sinus. First, we have seen tonsillolith. Next, we have anthrolith. Anthrolith is the calcification present in the maxillary sinus. You should not be mistaken for any foreign body present in the maxillary sinus. A 10-year-old female present to the pediatric dental clinic for her very first dental examination and radiograph. On review of her radio-opaque lesion at the apex of 3-5 extending coronal to approximate the mid-root was noted. Clinically had no caries lesion associated with, no signs of fistulous tracts present, and no percussion sensitivity was noted. It is identified as a dense bony islands. It will never produce any symptoms and is not interfering with the tooth also. And it is not producing resorption of the roots of the tooth. This we can very clearly identify, that is a 24-year-old male reported to the dental clinic for regular checkup. Clinical examination, radiographic examination revealed a well-defined radio-opaque structures in the upper anterior maxillary region. The mostly diagnosis is a supernumerary tooth, that is the mesiodens. Here we have that a 16-year-old male reported to the dental clinic for a regular checkup. The radiographic examination revealed a well-defined mixed density lesions and a radiolucent margins of the left mandibular region is noted. Retained deciduous molar is noted, as well as the most likely diagnosis is complex odontoma. We'll see the odontoma in the upcoming slides. In 71-year-old Caucasian male represents a dental clinic for initial exam. The radiographic examination revealed a radio-opaque mass with irregular border at mid portion of the right ramus. The mostly diagnosed, already we have seen a case like the tonsilloliths. Here, a 55-year-old African-American male presents the dental clinic for a dental visit. Upon radiographic examination, a mixed radiolucent radio-opaque lesion was noted at the apex of 3-5. The lesion had a radiolucent rim around the radio-opaque center. The patient was asymptomatic and tooth was vital. No expansion noted clinically. The most likely diagnosis is a focal osseous dysplasia. It's a form of fibroosseous dysplasia. This is a very common term or common diagnosis, that is of 13-year-old female represents to the dental clinic for routine care. Upon radiographic examination, a teardrop-shaped, well-defined radiolucency is noted between the right mandibular lateral incisors and canine, causing the displacement of teeth. Both the teeth were vital. The most likely diagnosis is a lateral periodontal cyst. Here we can see the displacement of the roots. A 77-year-old female present to the dental clinic for a routine visit. Upon radiographic examination, a linear radio opacity near the spinal column was noted. During extraoral examination, patient was asymptomatic. The mostly diagnosis is ossification of the styloid process. We have ossification of styloid process sometimes remain unnoticed. When it is severe, the patient has difficulty in swallowing, speaking, and also in turning the heads. So we hear this is X-ray has been diagnosed to have a calcified or styloid process. In this case report, what can we see? That is a 52-year-old male presents to the dental clinic for admitting visit. The radiographic examination revealed a dome-shaped radio opacity in the right sinus. Most likely the diagnosis is, here you can see the arrow. This is a antral pseudocyst. A panoramic image revealing a cystic ameloblastoma within the body of the left mandible. Note the inferior alveolar nerve canal has been displaced inferior to the inferior cortex, indicating that the lesion started superior to the canal. We have a unicystic ameloblastoma, ameloblastic fibroma. As we know that ameloblastoma is a very aggressive local and benign tumor. It sometimes causes destruction of the ramus of the mandible extending up to the coronoid process. So all the images we are displaying and the case presentations commonly we have obtained through the year-wise approach from the reputed journals and from the renowned textbooks of oral medicine and radiology. In this OPG, here you can clearly see the punched out appearance in the radiograph. That is a cropped panoramic film revealing a small punched out lesions of the multiple myeloma involving the body and the ramus. A characteristic feature of the multiple myeloma is the increased proliferation of plasma cells. So here we have a clearly punched out radiolucent lesion, which is a characteristic feature of multiple myeloma. This is a malignant neoplasm, that is the poorly defined border of a malignant neoplasm that has destroyed the bone between the first molar and the first bicuspid. The difference between the malignant neoplasm and the other thing is a squamous cell carcinoma or benign lesion is that malignant neoplasm, the borders are very irregular and it will not be corticated or sclerotic. It will be very irregular and poorly defined borders we have in case of malignant neoplasm, that like a squamous cell carcinoma or like in a metastatic carcinoma. Here you can see that the odontogenic keratocyst or keratocyst odontogenic tumor, depending upon the nature of the epithelium and the tumor-like behavior of the epithelial cells displaying a scalloped border, especially around the apex of the associated tooth. Here we have a leukemic infiltration of the mandible in case of leukemia, showing coronal displacement of the developing second molar for the remnants of the script. There is a lack of lamina dura around the apex of the first molar and widening of the periodontal ligament space around the second deciduous molar. So when we see any radiolucent lesion, we should check for the different provisional diagnosis before coming for the final diagnosis. Here, this OPG can be clearly used for the visualization of distordents in both in the maxilla and also in the mandible. And for the evaluation of impacted tooth, we'll also clearly visualize in the OPG. First image is a dilated odontome. The most severe of the enamel invagination is its position just posterior to the developing mandibular third molar. Odontome, we have a compound odontome, complex odontome, and the complex composite odontome. Compound odontome, it remains like a tooth-like structure. We call it as a compound, and it is a complex or composite odontome. We have the structure will not resemble close to the tooth. In all the odontome, we have a fibrous capsule surrounding the odontome and see the internal laminated pattern. The thin radiolucent rim is surrounding the odontome. It is a characteristic feature to identify the odontome. Next slide, we can see the dentigerous cyst is characterized by the bulbous crowns, constriction of tooth at the cemento-enamel junction, short roots, and reduced size of the pulp chambers and root canal. Pericoronitis, so for the evaluation of pericoronitis also, we can take the OPG that is related to the periapically erupted third molar. Note the sclerotic bone reaction adjacent to the follicular cortex, and the periosteal reaction is also we can note it in the OPG. Next, in the panoramic film lives a large sequestra on the periosteal reaction at the inferior body of the mandible in case of chronic osteomyelitis. So we should never miss these diagnoses of a linear structures which are present in the OPG. Next is that we can see the oroantral communication, that is made by the burrs. First image OPG is the oroantral communication which is produced due to the fracture of the burr. Next, in here also we can see a fistular tract extending inferiorly from the apex of the first molar through the inferior cortex of the mandible. Here clearly we can see the dentigerous cyst displacing the tooth. The third molar has been displaced to the inferior cortex, and the developing second molar in the image B has been displaced into the ramus by a cyst associated with the first molar. Here you can see the wide extensive destruction of the maxilla of the mandible. The most common dental cyst, we call it as a radicular cyst, originating from a non-vital deciduous second molar, show the expansion of the buccal cortical plate to a circular hydraulic shape and the displacement of the adjacent permanent teeth. In OPG, we cannot see the extension of the cyst or tumor in a buccolingual direction, and also the difference between the expansion, whether it's a cortical expansion or lingual expansion or buccal expansion. To rule out the expansion of the cyst, clearly we have to go for the occlusal radiographs or a CT. Next, we have a keratocystic odontogenic tumor. It has been called as a cystic lesion, has been named as a tumor because the epithelial cells have a tumor-like characteristics, and keratin formation is also present. Since they are mimicking like tumor-like characteristics, we have called it as a keratocystic odontogenic tumor. Here we have a unicystic ameloblastoma developing occlusal through the left second mandibular molar, causing expansion of the mandibular body and ramus to the sigmoid notch and the condylar neck, and inferior displacement of the mandibular second molar and root resorption alveolar left first molar is noticed. So once we have a wide destruction of the mandible, we have a variety of differential diagnosis. So we have to rule out the differential diagnosis, whether it is associated with the impacted tooth or is associated with the non-vital tooth or it is associated with the crown of the tooth. Then we have to, depending upon the nature of the lesion, we have to come for the final diagnosis with the help of the biopsies. Next, we have ameloblastic fibroma in the body and ramus of the mandible. Here also we have a series of complex odontome. Note the tooth-like density of the internal structure, a thin radiolucent capsule that in many cases interfere with the eruption of the associated tooth. The odontomas are of clinical significance. If it is interfering or associated with the tooth, it has to be removed surgically. Sometimes the odontoma remains asymptomatic. Next, we have a soft tissue hemangioma, that is a hemangioma, deposition of debris in the veins, or we call it as a phleboliths. Here, next image, we can see that the squamous cell carcinoma, that is the lack of bone reaction at the margins of the tumor because the lesion is not producing any cortical border or sclerotic border, that is, and the periosteal bone reaction is not noted in the squamous cell carcinoma. Let's see about the condylar hyperplasia involving the right condyle. Usually the condyle is ovoid in shape. The different dimensions of condyle are from the anterior to the posterior. It appears that is 8 to 10 millimeter in length. From medial to lateral or lateral to medial, it appears 15 to 20 millimeter in length. Anything which is away from the measurements we represent as a condylar hyperplasia. What happens when condylar hyperplasia, that is deviation of the midline, occurs and there is a crossbite on the contralateral side? To rule out the facial asymmetry, we can go for a PA skull view. See here, you can clearly visualize the asymmetry produced by the condylar hyperplasia. First, condyle is the growth center of the mandible. Usually, the growth of the condyle stops after 20 or 21 years of age. To predict whether the growth center is still present in the condyle, we have to go for the different modality of scanning like a SPECT-CT, PET-CT or bone scintigraphy to rule out the hot spot in the condyle. Next, what happens is the hypoplasia of the left condyle. Here you can very well clearly differentiate in this OPG differentiation between the right and the left condyle. That is, the condylar hypoplasia can be restricted towards the condyle head and neck with minimal involvement of the mandibular ramus and the body. Both condylar hyperplasia or condyle hypoplasia can be congenital or it can occur due to any trauma which is occurring at the childhood age. Here we can see the condylar neck fracture, that is, the arrow points to the overlapped fragments as evidenced by the increased radio opacity. Submandibular gland cylolith clearly visualize a radio-opaque structure position and also the laminated internal pattern. What is cylolith? Cylolith is the deposition of calcium crystals in the salivary gland, mainly the submandibular salivary gland or in the parotid salivary glands. For in the occlusal radiograph, while taking occlusal radiograph, if the submandibular cylolith present only in anterior 2/3 of the duct, we can clearly visualize it in the occlusal radiographs. Otherwise, we have to see a OPG or a CT scan. Next, here we can see a cylolith involving the parotid gland. The parotid gland is difficult to diagnose a cylolith because of the tortuous course of the Stenson's duct and due to overlapping of the masseter and the buccinator muscles. We can clearly visualize the cylolith in parotid gland if it appears anterior to the masseter. The normally calcium crystals or calcium phosphate or calcium hydroxyapatite crystals are deposited in the cylolith. Here we can see that the prominent ossification of the stylohyoid ligaments. Usually these individuals did not have any symptoms. If it is severe, will produce severe dysphagia, pain while turning the neck and pain during swallowing also. On the calcification, here we have different form, that is ossification and calcification. That is, ossification means here we have the formation of bone cells. In calcification, we have deposition of the calcium crystals. Last but not the least, we are coming to that OPG can be also used to interrupt the placement of the implant for pre-operative investigation and also to decide the placement of the implants, and it can be also used for the post-operative evaluation to visualize the implants. Here we can see the threads placed in the different implants. That is used for post-operative multiple successfully restored root form implants. The threads are visualized on all of the implants except for the mandibular right premolar, which is the smooth cylinder. Later, we are coming into the end of the session. That is the advancement in the OPGs. Here we have a cone beam computed tomography. In this fan-shaped beam is produced. On concluding, we have a panoramic radiograph approved to be a good adjuvant radiographs to conventional intraoral radiographs, mainly because they produce a single tomographic image of facial structure that include both the maxilla and mandible and the supporting structures. Diagnostic value of these films is increased considerably if clinicians are aware of the limitations and apply a systemic approach to its interpretation.